Welcome, everybody. So great to have you guys on a Thursday evening, cold night, joining us in this wonderful event that we're going to have together. I am Iman Majd. I am the director of the Osher Center for Integrative Health at the University of Washington. And I will be telling our story a little bit, and after my story, then we'll have Dr. Grabowski doing the presentation. So let's start with where we are. The Cha Chiming Education Series. The Cha Chiming is the name of the gentleman who his family on his behalf are giving funds to the University of Washington Department of Internal Medicine for the education of integrative medicine. And I have the honor of being the steward of those funds, and we use those funds to do educational training and educational presentations in the field of integrative medicine for public through the Osher Center at the Department of Family Medicine. The Osher Center, Osher is the name of the gentleman out of San Francisco who endowed the initial funds in 2018 to University of Washington to create a Center for Integrative Medicine and Integrative Health. Currently, there are 10 centers across the country in different universities like Harvard University, University of Washington, UCSF, Vanderbilt, Northwestern, Utah, University of Utah, University of Cincinnati, University of Miami. So collectively, 10 centers across the country and 1 center in Sweden, University of Karolinska. So 11 centers of Osher centers, and they're all different in what they present and what they offer. We came into existence in 2018 through the endowment, and currently we have a very strong team. We offer acupuncture, we offer integrative medicine consults. We just started offering naturopathic consults, and we are very proud that for the first time we actually accredited and credentialed a naturopath into the system to do consult in integrative medicine for us. We just hired a massage therapist that's going to start with us in January. And our mission is to bring together conventional and complementary practices to promote health and well-being and illness prevention. We emphasize on a holistic and person-focused approach to healthcare and wellness, treating the whole person. We are a clinic without borders, without walls. We use other clinics' space, and I personally hope for the day that we have enough funding that we can actually have our own clinic and have our own services in our own clinic. But right now, we are a clinic without borders using other clinics' spaces. A little bit about Cha Chiming. This is my dear friend, colleague, mentor, and coach, Emily Wong. Dr. Emily Wong worked many years at the University of Washington. I believe she was the vice dean in the Department of Internal Medicine. She has dedicated her life to women's health and also integrative medicine. Currently, she's practicing in Hong Kong, where her family is. And the fund came from Emily's family. Cha Chiming was Emily's grandfather, and the Cha Chiming Endowed Fund for Integrative Medicine was established for the purpose of promoting and understanding and translation of research findings in integrative, East-West, and other complementary and alternative medicine disciplines in the Division of Internal Medicine. The endowed honors Cha Chiming, an industrialist and philanthropist who had an abiding fascination with the potential contribution of traditional Chinese medicine modalities to modern biomedicine practice. This endowment presents a personally significant component of Mr. Cha Chiming's legacy. So we are very thankful that we do have access to those funds through the Cha Chiming family and Emily Wong's family, and we are hoping that we can use these funds for the years to come for more educational activities in the field of integrative medicine. This is what we did this year for the first time. We had this virtual presentation with the theme of brain health and nutrition. So we had 5 sessions. They're all recorded, and you're interested, you can go to our website, and if you scan that QR code, it will take you to the recordings, and you can watch the recordings. In 3 of the sessions, we partnered with a chef, and people actually cooked with the chef. As he was cooking, we would send a recipe to the individual, to the participants, and they would cook with the chef. And the theme was anti-inflammatory diet, gut and brain health, and the whole theme was brain health and nutrition, what to eat and what not to eat to have a healthy brain. When I brought this to Emily's attention, she made a comment that you have to go to Memory Hub and you have to go and meet my dear friend, Tom Grabowski. And I said, sure, I'll do so. So I think it was during summer that I came here and we met. It was a pleasure to meet the Memory Hub and what they do there. And we kind of wandered around, looked around a little bit, and said, how about we use your space? Because we have an event coming up, and we would like to talk about brain health, and how about using your space? And they gracefully agreed. They said, sure, we would love that. And the next thing was that, Tom, how about you being our speaker? And said, sure, what I'm going to talk about, and said, whatever you like, but it has to be brain health. So that's how we ended up here for tonight. And I think everybody here to some degree knows Dr. Grabowski and his work. He's the director of Memory Hub. And I'm going to let him do the introduction himself. We kind of went back and forth in the beginning that who does the introduction, but he is extremely achieved and well known in the field. And I would like to take a moment to thank him and his team for all the great work that they have done in the Memory Hub. You saw some of the work, some of you are familiar with the work they are doing. I don't know if they have ever had a platform to showcase their work, but I hope that this is one of the platforms that they can use to showcase their work. It's an amazing service to the community and to people living with memory loss. And I'm hoping that moving forward, we can collaborate more and create this platform that we can serve our communities and our trainees at different levels. Before I hand it to Tom, I also wanted to thank my team at the Osher Center. It was not easy to put this program together. It has been a lot of work, and I'm extremely pleased of being here and having this pleasure of being in front of you and presenting. One of the members of the team has recently joined us, and she has put a lot of work into making this happen. And we had never met before until this moment. And that is Carolyn Kim. I would like to thank Carolyn for all her work. And And with that, I think we are ready to start the program.
Hello, everyone. My name is Mary Grace Becker, and I know many of you, but I'm the director of the Memory Hub, and Dr. Grabowski is my boss. He's the director of everything. And it's my pleasure to be able to partner with the UW Osher Center tonight, and they asked me if I might care to sing a little song about the, well, it was make a video about the Memory Hub, no, a PowerPoint, how about a song, because I love writing songs. So anyway, I'm just going to sing a little song about the Memory Hub, and then turn it over to Dr. Grabowski. But in a nutshell, as you hear, the Memory Hub is operated by the UW Memory and Brain Wellness Center as a whole. It operates like a community center or senior center that serves people with memory loss and family members, and also fosters collaboration among like-minded organizations. 5 different organizations that work there on site with the UW. The Fry Art Museum is a partner, Whole Life Care, the Alzheimer's Association, for a variety of programs and resources, including our resource center and library, a memory garden, lots of classes, programs, support, and education. So I'm just gonna sing for 30 seconds or so, and there's one line that you all can join me in, which goes like this. It's the Memory Hub, hooray. Try singing that with me. It's very simple. It's the Memory Hub, hooray. Very good, okay. There's like 6 little mini stanzas, and then we'll move on. A place for you, a place for me, a place for dementia-friendly community. Here we go. It's the Memory Hub, hooray. We work together, collaborate. We spread great programs across the state. It's the Memory Hub, hooray. Groups for support and brain health talks. A world of resources and garden walks. It's the Memory Hub, hooray. You sound so great. Connect with those who understand, who will walk beside you and hold your hand. It's the Memory Hub, hooray. If you like songs or making art, come right on in, we've got a place to start. It's the Memory Hub, hooray. Last stanza, discover strengths you've got inside. Lift up your head and walk with pride. It's the Memory Hub, hooray. Thank you very much. Thank you for singing.
I think it's obvious I need to up my game here. It's a lovely introduction, Iman. See if I can master the pointer here. So nice to be with you tonight. I see a lot of old friends, a lot of new friends, old colleagues, new colleagues in the audience. And it's, as Iman said, we've been trying to get together with the Osher Center now for some time, and this is a really nice opportunity to talk about our common interests. So that's great too. We're also interested in collaborating. So we're here to talk about living well with memory loss. My own journey here has been over the last 10 years or so. We just celebrated the 10-year anniversary of the Memory and Brain Wellness Center at Harborview, which I direct. And the Memory Hub that you're hearing so much about is Mary Grace's brainchild, but an outgrowth of our programming that has exceeded all expectations in terms of what we've been able to do with it. I also direct the Alzheimer's Disease Research Center, and one of my jobs is to make sure the research, clinical, and outreach pieces all work together in a seamless whole, and they're all stronger together. So tonight we're here to talk about the overall philosophy of what we do at Memory and Brain, and as you'll see, this is a sort of positively framed approach to memory loss. So let me first level set a little bit with you about aging and memory loss and dementia. So first of all, we're not calling this cognitive aging, we're calling this adult cognitive development. Okay, there is such a thing as adult cognitive development, and I don't know if you can see this very well. These are just various aspects of our thinking and memory over the decades, from 25 to 90 years of age. And the first thing to see is people get better and better and better at things up until their 40s and 50s. The development is not just something that happens in childhood and your educational years, but this is something that goes on. And yes, there is some decline with later years, but it's most of us age very successfully and do not get into a serious amount of memory loss. We have normal cognitive aging, and that you'll probably recognize this. I recognize this in myself. You think a little more slowly. You have word finding trouble, name finding trouble in particular. How many people are experiencing tip of the tongue that starts, as far as I could tell, about age 30? Less efficiency on memory retrieval. The material is there. You just can't always get it when you want to. You try next week and you find it pops right up into mind, huh? And just less intense concentration and attention. Imagine a 20-year-old in their game platform. We may not have that intensity anymore. But none of that amounting to any impairment of daily living, right? That's normal cognitive aging. If you have pathologic cognitive aging, for example, you can't remember recent events that are important to you and you don't recognize even that they have happened, that's the kind of memory loss which is not normal at any age and the kind of thing that we're here to talk about. So, but staying with normal cognitive aging, there's been a lot of work on how you maintain that, how you prevent decline, functionally significant decline. The cover here on your right is on a very authoritative report that was authored by the Institute of Medicine, looking at all the knowledge base about how to prevent cognitive aging. And the one thing that seems ironclad there is physical activity, regular physical activity, well documented to preserve cognition for some reason. The other, kind of bulletproof recommendations are things like reducing and managing vascular risk, social and intellectual kind of habitual engagement, and adequate sleep and treating sleep disorders. And you've heard a lot about a lot of these topics in the Osher series, especially around managing vascular risk and good nutrition, and that's all great. And serious decline is just not a universal thing, but there is a component of us that encounter more serious decline. Are the lights flickering, or is it just me? I'm worried that the projector's about to tank on me. A lot of this work was done as part of this landmark study called the Seattle Longitudinal Study. But if you look, you can divide all of us into those who are successfully aging, who are typically aging, or unsuccessfully aging. And it's really interesting. There is this group, and it's kind of marked by the open white bars here. There's a group of people that just get smarter and smarter, just do better over the years. And then there is most of us. And then there are these black bars, people who are having trouble and may cross the line into what we would call dementia. Okay, and that's what we're here to talk about tonight. I have to do a shout out to my former neighbor, Mr. John Halver, Dr. John Halver, my paradigm for the super successful ager. I met him at age 87, my across the street neighbor. You can see he was a professor. He was the father of fish nutrition. He was in the National Academy of Science. Gladiolus cultivator, master gardener. He would roll down the window on his way to church on Sunday, wave to me and say, "Tom, we have a new finding." And then at age 90, he passed away suddenly. He was healthy in the morning, and he passed away abruptly. So his curve was totally squared, if you will, and maybe almost a sort of ideal trajectory, right? Functioning superiorly to the end. But what about people who have more serious trouble? So I have a counterexample in mind. I have a patient who's a 50-year-old physician, and she's been a runner. She's got exemplary nutrition, and yet she has Alzheimer's disease at age 50. So there's something else going on, supervening on top of the normal aging processes. And so let's talk about that a little bit. So just, again, level setting with you. We talk about two levels of diagnosis with memory loss. One is what's the matter with memory and thinking, and that's what we're talking about here. And that sort of begins with some subjective concerns. I actually put normal subjective concerns because I dare say it's a normal part of aging to be concerned about your memory. Okay, most of us are concerned on some level. But when you cross the line there, where you start to have objective impairment, where where we give you a test and you're actually having trouble performing that test, we start to talk about something called mild cognitive impairment. Now, this is something we can measure. It's not necessarily preventing you from doing your job, or certainly not from doing your daily accustomed things, but it's still a problem, and we'll talk more about this. And eventually, you may cross a line where you're materially dependent on your family or other people for things, and that's what we mean by dementia, when you have an objective impairment and you also are dependent, okay? So that's one level of diagnosis. And then we have a second level, which is, okay, so what's wrong with the brain to explain that, if you could look under the microscope, okay? And that's where we start to talk about Alzheimer's disease, which is a biological thing, what you would see under the microscope. And what you see is two things. You see these amyloid plaques in the brain. These are clumped up amyloid protein, and that'll become, I'll mention it again just a little bit at the end. And then you have these other marks, which are called tangles, neurofibrillary tangles, and they sort of mark the neurons, the nerve cells that are dying in Alzheimer's disease. And that's what Dr. Alzheimer there saw, and that's why we call it Alzheimer's disease. If you have dementia and you have that under the microscope, that's Alzheimer's disease. Everybody with me so far? Okay, so that's all background. So now, if you look at the red line here, the red line over, the decades from 30 to 90 or so, you see this red line, that's the rate of Alzheimer's disease dementia in the population, okay? Hardly anything until 60, 65, and then it sort of increases exponentially. The blue line is how many people would have a amyloid PET scan, which is positive. So we now can measure the amyloid protein that makes those plaques in Alzheimer's disease with a brain scan. And you can see that blue line looks parallel to the red line. It's just 15 years earlier. So what that means is 15 years before you have symptoms, your PET scan is abnormal due to Alzheimer's disease, okay? And one reason I want to show this, there's the PET scan, is if you just look at that 70-year mark, go up to the blue curve and over to the other side, you see that's 25% of us at age 70 would have a positive amyloid scan, okay? So this is something that affects a lot of us, I dare say, in the room and in our society, and it's a major issue. And most people are framed on dementia, Alzheimer's dementia, but there's this big piece of the iceberg under the water, which is the people with mild impairment or no impairment who have Alzheimer's disease happening in the biological sense. Okay, is that good news or bad news? I would say it's good news in the sense that there's a big period of time where if we could detect this, we could intervene and slow it down. We wouldn't have to stop it. We could just slow it down, and we could cut dementia seriously in half if we could just slow it down for 5 out of those 15 preclinical years. And so now we've learned that that's what we have is not just a dementia due to Alzheimer's disease, but this period of 5 years or so prior to that is manifesting as mild cognitive impairment, and the 15 or more years before that are truly preclinical, where we can't measure anything the matter with memory or functioning. And in fact, there's really no way, or has been no way, to tell that from the typical aging trajectory. If you go back to Dr. Shaya's Seattle longitudinal study and the people that were unsuccessfully aging, it's probably this group, okay, by and large. It's where we intersect with our colleagues in the Osher Center, right? So there's no, in typical aging, functional medicine and holistic approaches are all great and helpful, but there's something else happening with Alzheimer's disease that's making that not enough to keep people from declining. All right, so now I'm going to introduce some of the concepts that we use in the Memory and Brain Wellness Center. So the first thing is, well, that relationship between how badly your brain is affected and how badly your memory and thinking is affected, that's modifiable, that's malleable. So there are some people who are walking around who have advanced Alzheimer's disease by imaging or by, you could look under the microscope, but they don't have much to show for it. They don't have much, they don't have dementia, they may have only mild impairment. And that is a situation which is facilitated by how well educated you are, how challenging your job was, how much time you spend in cognitively enriching activity every week, how much exercise you get, how much social connection you have. And that's a phenomenon we call resilience to Alzheimer's disease. You still have it, but you don't show as much effect from it. Your function exceeds expectation given your disease stage. Okay? That's something as a center we're intensely interested in because it's got to be an important clue. Right? It's got to be an important clue. We do not really understand the biology of resilience yet. But it's very important. And this is they didn't present this graph the best way in the paper, but I just wanted to show you how big this effect can be. So this is a Mayo Clinic study, and they capture everybody in Olmsted County, Minnesota, and they have a pretty good read on what's happening in the general population. And they looked at factors like educational and occupational challenge, and they looked at on people's cognitive habits in early, like midlife, and then later in life. And they asked the question, okay, so if you're an 80-year-old person who's got normal memory, but you have this genetic risk factor for Alzheimer's disease, how long until you're going to have dementia? How long on average? And it turns out to be modified by these factors, okay? And so this is, low to high education and occupational challenge, and this is how many years to get dementia. And you can see the red line, the green line, and the blue line. The distance between this point and this point is about 7 years on the x-axis. So that factor makes 7 years of difference in when your tipping point is on average, okay? And likewise, your cognitive habits, if you go from low to high habits, that makes another 4 years of difference, okay? So it's collectively about a decade, maybe 8, 9, or 10 years in where the tipping point is. And just for reference, this genetic risk factor, that makes about a decade difference too. So it's, it's a realistic amount of cognitive habits and a realistic amount of education goes a long way toward prevention of dementia. Okay, so this resilience is a big factor. I think resilience is related. There's not just adult cognitive development, there's adult brain development. I'm not going to spend any time on this slide except to point out the brain is not fully architected by the time you're in high school. It's still developing. This is the gray matter curve here. That sort of peaks out around age 32. The white matter, maybe age 45. So there's a lot of development happening through the decades of midlife in the brain. That's just what you can see on a brain scan. At the microscopic level, probably much longer than that. So there's a lot of sort of exercise that you can bake into the brain, if you will, if you use your brain through that period of time. I love this. I found this. I remembered seeing this when I was a kid, and I looked last night, and I was able to find this quote. And I love it, except I wouldn't cross that off. A mind is like Jell-O. You need to put stuff in there before it sets. And we'll return to this concept later, because even when people have memory loss, it's not too late to put more stuff in. Okay? All right, so what we've learned about resilience is there's this long pre-symptomatic window and your cognitive lifestyle over the decades makes a difference in resilience to Alzheimer's disease. And these factors can postpone your tipping point, really literally by years. And like I say, this is an important clue to future treatments. As a center, this is a major research focus for us. Sort of exploiting all these ideas, there was this study that was published. It's been a few years now, called the Finger study. Finger has spawned a whole set of studies called worldwide fingers because it was so important. But this study was done in Finland, and they looked at a bunch of seniors who, they sort of stacked the deck. They were already, they had a high risk of dementia because they may have had some vascular disease and hypertension and other things. And they were the people that were sort of in the lower half of the scores on the tests that they did to screen people. So they sort of stacked the deck for people who were at risk for losing memory. And they made this multimodal intervention. They worked with people on their diet. They worked with people actively on exercise and on cognitive training and monitoring vascular risk. And then one of the only graphs I'm going to show you here, over 2 years, the intervention group, which is red, and the control group, which is blue, separate significantly on a measure of cognition. Okay, so these things make a difference, and it's not too late, even when you're already sort of leaning into a higher risk category to make interventions like this and build resilience. So that's the first kind of principle I wanted to get across to you, this idea of building and trying to maintain resilience to Alzheimer's disease. The second thing is Alzheimer's disease does not affect the whole brain the same way. It affects some parts of the brain hard and early, and other parts are relatively or even completely spared. That's obviously a brain. This is color-coded brain, where red means that's where there's lots of Alzheimer's tangles. And this area, which is really sort of ground zero, is this structure that's this kind of curled up structure that has reminded people of the appearance of a seahorse. So it goes by the Greek name for seahorse, which is hippocampus. And the hippocampus is ground zero, and that's a miraculous structure in the brain. That is what helps you encode new memory. That's what detects that something is new and writes it down without you even have to think about it, okay? That's your secretary, if you will. And that's where the trouble is first in Alzheimer's disease, and that's why people present with memory loss for recent material in Alzheimer's disease. So that's what happens, but it turns out that other parts of the brain aren't so involved, and it turns out that memory is not just one thing. So there's other parts of memory which are working better, and I bet everybody knows, about procedural memory. This is your muscle memory or the memory to develop a new habit or a new skill, like riding a bicycle. How many people remember Wii bowling? Did anybody do Wii bowling? Wii bowling was like really hard to do at first, right? And you get much better at it. Well, people with memory loss can learn Wii bowling just fine. Thank you very much. But there's an important lesson here, which is besides trying to build to reconstitute cognitive function by doing mental exercise, you can work on a strategy of compensating by leaning on these spared capacities. And we've had a whole program built around this. I know there are some members in the audience who've been through the ADAPT program here. One of the principles of ADAPT is to use this spared procedural memory to compensate for your impaired episodic memory. So, things as simple as the habit of, the memory notebook, or the memory device, I guess some people would use, that's always in the same place and is your go-to, and you build that habit. And did I say always? Mindfulness meditation is a great kind of stress reduction technique, but it's a procedure. It's something you learn. It's something you get better at over And ADAPT is built around this, it's a sort of a 2-week boot camp, but it's built around this idea that we help you get on the road to developing these habits, which are going to help you prolong your functional independence. That's just one example. Another of the spared capacities that people have is the creative impulse. There's something very central to our humanity that wants to be creative, that has this sort of drive to put things together in a pleasant or just intriguing way. And visual art programming turns out to be a great way to tap into this aspect of strength. You didn't see our memory garden next door in the daylight tonight, but there's some beautiful artwork, some fused glass work here that was done by one of our patients or one of our people living with memory loss. I can share the story. This gentleman is a professional negotiator. He's having some trouble now, but he said, I have to get the glass to negotiate. He says, the fusion it's a process of making these materials work with each other. And he's kind of found a way to sublimate some of his purpose, with visual arts. And I'll talk about another aspect of spared capacity. This work that we did at University of Iowa, and this is really interesting. Do people recognize the tangrams here? Probably a lot of households have a set of tangrams sitting around that you can take apart and make into different figures. So in this, I'm going to tell you about a little game that's played with tangrams. I'm sorry about the flicker. I don't know what's causing that. Here are 12 tangrams. They're not easily named. And they're ordered 1 through 12. All right, so here's a game that's played with these tangrams. And so we have, I'll call her Kathy. Kathy is got normal memory. And I'll call him Ken, and Ken has Alzheimer's disease. They have a screen between them, and there are, the 12 tangrams are in order on Ken's side of the screen, and Kathy has to put her tangrams on the right spots, only under Ken's verbal instruction, okay? And Ken has Alzheimer's disease, okay? So they have to negotiate, and Ken will say something like, well, there's one here, it looks something like a kicker. Do you know which one I'm talking about? And Kathy will say, well, I see something that has such and such and such and such. And Ken says, oh, it's going to be that one. And they kind of work on stacking these onto the right numbers. How long do you think it's going to take Ken and Kathy to do this? Do you think this is easy or hard? So normal people take 10 minutes to do that. So it turns out that you get better at this. You and your partner have, you have common ground. You start to hear how each other think about these tangrams, and the next day it takes you about 8 minutes, and the next day it takes you about 4 minutes. And you get this down to a couple minutes or maybe 1 minute. Here we go. Okay, so you get this down to a minute by the 12th day. All right, so here's what happens with people when this game is played where the director, Kathy's job, has Alzheimer's disease. It's the same line, okay? So someone with early Alzheimer's disease can do this normally, okay? Now, if the job was different, if Kathy's job was to learn a set of arbitrary names for these things, that one's a kicker and that one's a such and such, she would fail miserably. The reason this succeeds is that she and her partner have this common ground, and she's not required to have a particular name for it, just one that Ken will agree with her on. Okay, and so it's a social exercise. And in the social context, people can function much better. And everybody's probably heard stories of couples where they seem to be doing really well, and one member may pass away, and the other person is suddenly found to have Alzheimer's disease, right? And suddenly not functioning well. Well, maybe the other person was compensating for that person. I don't know. I think maybe they were functioning as a unit, okay? But this social learning is important, and it's one of the spared capacities. Okay, so we call that working from common ground. And what we've learned is that, in summary, Alzheimer's disease tends to spare certain brain regions, and these support these retained strengths that we can tap into, for therapy. So motor and sensory abilities, which I didn't talk much about, but people experience their motor and their sensory experience of the world, by and large, pretty normally. Learning new skills and habits, accessing memory from sensation, experiencing the world in the moment, creative impulse, learning in a social context. All these are strengths that we can try to work with. And so I think you've got the picture here. We're really trying to reframe a scientifically grounded, positive, and forward-looking view of brain health, and to bring this to our patients that are living with memory loss. And we've talked about the principle of building resilience. We've talked about the principle of strength-based reframing, which has to do with understanding Alzheimer's disease across all its stages and the abilities that people retain in the midst of them. And then the third big idea that we've had is this idea of dementia-friendly community, which, and this is what we try to embody at the Memory Hub. It's where people with memory loss and dementia are understood, included, and empowered so as to live well and to their potential. And to really explain that well, I do need to talk more about the Memory Hub, because this aspect of our work has an address, which is 1021 Columbia, and you've had a chance to see that space. And one of the main purposes of the Memory Hub is to really model this idea of dementia-friendly community. So we have, as Mary Grace mentioned earlier, what feels like a community center. There's a library. We've been treated very generously by the Seattle Public Library, and kind of beefing up the offering in that library. We have a memory garden, which we've also had a lot of generosity in building the memory garden, which should be attractive all year round for our clients. Has a lot of social opportunities and spaces for those opportunities. And you saw also the gallery of community-produced art in the central atrium, which kind of rotates. And you may not have seen all of the artwork, but there's some really interesting art on display right now. More deeply, we're about education of patient and family around these principles. We're about incorporating people living with memory loss in our programming, helping us, advising us in our programming, helping us develop the handbook that we use for our programming, peer mentors in our educational sessions, and so forth. And a lot of credit to Mary Grace for really keeping that a major living principle in the center. And, as you can see, we really challenge people's stereotypes of dementia. I bet you've learned something about memory loss and Alzheimer's disease that you didn't know before. And I'm particularly proud of setting up all kinds of collisions. So we bring our research colleagues out to have their symposium in this space because we want them to see these ideas. This whole operation is really out there for UW. I don't know another community center University of Washington is kind of standing behind like this. And it's great to have leaders from Harborview come over and see what we're doing and say, oh, that's really cool. And then we're also a major kind of part of the changing fabric of First Hill. There are at least 3 major senior living centers on First Hill right now. And a lot of other programs that are well aligned with what we're doing. This year we had the First Hill Brain Health Block Party, and there were, Mary Grace, 7 stations around First Hill, something like that. A lot of people, we actually kind of hit it out of the park with this one. There was a lot more participation. We actually also had a very perfect day for it in Seattle. So that was this all sort of promoting this idea of dementia-friendly community. So besides incorporating our programming from our clinic, so some of you know about these programs, but we have a one-time 90-minute Zoom class, which is we started in person, but we were able to move it to Zoom during pandemic, that introduces a newly diagnosed person and their family to our memory handbook and the resources we have at the center. This is the program that involves the peer mentors I mentioned a little while ago. I've mentioned ADAPT. We have a garden discovery program and much more. We also house programs that are state-funded through the so-called Dementia Action Collaborative, which is implementing the Washington State Plan to address Alzheimer's disease. And Dr. Rhodes, whom you see here, is a leader in this area. He's been really an active component, an active person in the Dementia Action Collaborative itself, and runs a sort of telemedicine version of a continuing education program or not continuing, just an educational program for primary care physicians statewide, and has reached 130 plus physicians. Oh, he's pointing up 150 in all corners of Washington State. And we've been entrusted with some of these resources from the state because they know we can disseminate this work statewide. And then, as Mary Grace mentioned, we have aligned partners who are on site with us, including the Alzheimer's Association. There's a young woman from Alzheimer's Association here today. The Elderwise Adult Day Program, which is a model program using creative arts and much more. I encourage you to learn more about that. And we also have Full Life Care, which has a program in caregiver education. So these are some of the things we're doing at the Memory Hub. So let me shift gears a little bit and just tell you how much all this has sort of transformed the landscape about how we approach memory loss in the clinic. Because when I was first in this field, which was 1990, we were encountering people here in dementia. I used to lament that, someone's already run down to about the 10-yard line before anybody's decided to try to tackle them. What's the chance you're going to prevent the goal at that point? And all we had was medicine that basically would cover some of the symptoms. Now, we're by and large starting to encounter people in this mild cognitive impairment stage instead. That's a world of difference. There's a lot more we can do at that stage. And we've been, all these things I've been telling you about, building and maintaining resilience, are messages that we have been promulgating. Building resilience, leveraging retained strength, and building dementia-friendly community. We still have the symptomatic medicines, and we're just starting now to roll out the first disease-modifying medicines, which we're now able to actually give in mild cognitive impairment stage instead of here. And it turned out that they're not effective here, they're effective earlier, right? So our goal is intervene and delay progression so that hopefully in the end, people don't get to the dementia stage, if that makes sense. So all this really to counter, this kind of prevailing idea about Alzheimer's disease, which is sort of what we have called the narrative of loss, right? Because when you say Alzheimer's disease, what do you think of? What do most people think of? Dementia, loss, no hope, and so forth. But I think it belongs in a much wider frame. I think, it's not just dementia, it's mild cognitive impairment. It's earlier than that, subjective memory loss, even normal cognition with Alzheimer's disease happening. And we talk about things like engaging strengths and building reserve, living well with memory loss, or even prevention, right? So prevention becomes a realistic strategy. We've tried to embody all of these principles in the handbook, which we've developed for our patients. Some of you have used this handbook, which we're proud of. And that's where we sort of have been, at this point. I'm going to show you two slides about how the whole thing is now kind of, we have a sort of disruptive development, which is now we have the first disease-modifying treatment for Alzheimer's disease some people in the audience probably heard of Leqembi or lecanemab. This is not a cure for Alzheimer's disease, it's medicine, but it is a step in the right direction, and for people with mild cognitive impairment, this can actually be really helpful. It does remove the amyloid protein from the brain, which is remarkable, and it has a more modest but definite effect on the trajectory of cognition, so people may still decline, but at a slower rate than if they're in the placebo group. And so we're just starting to get some experience with this. And the other disruptive development is now you don't need a PET scan to find this. We're realistically finding this in blood tests. Okay, so you haven't heard a lot about this yet, but I guarantee that these are commercially out there in the next 2 years. Okay, they work really well in the research setting. So, and the lecanemab story is going to drive their marketability. So they're coming, we're looking at a future where instead of diagnosing a mild cognitive impairment, what I think in 2030 is we're going to be diagnosing over here. You're going to get your blood tests, at your 55-year brain wellness or a wellness visit, or maybe your 60-year-old wellness visit, and we're going to detect things and maybe start intervening before you have symptoms, right? So that's kind of the future. And that disease-modifying thing is now introduced even earlier. And then finally, on my last slide, I just want to say, just blue sky at a second. So what does all this mean? What is the future of memory care really look like? And try to put some of this together for you. And the first one is this point that I made that these blood biomarkers are really poised to make preclinical detection possible in primary care. Okay. And that would make it possible to do what we call secondary prevention of Alzheimer's disease, meaning beginning when in a stage before you have symptoms, sort of like you do with your hemoglobin A1C, right? How many people have elevated hemoglobin A1C, which means you have diabetes, but you don't have full diabetes yet? That's what we detect in primary care and make an intervention so you never really develop full-blown diabetes. So I think that's what's coming, an intervention earlier. Right now we're doing a lot of cognitive assessment to try to make a diagnosis, figure out what your diagnosis must be. I think eventually that's going to take a backseat to biomarkers, and you're going to be able to say definitively is Alzheimer's happening or not based on a biomarker test. But you were still going to need that cognitive assessment for defining people's strengths and tailoring their therapy program. Okay. We're really just scratching the surface about how to exploit the retained strengths. And then these non-pharmacologic approaches I've been talking about, nobody's really tried to systematically combine them with these disease-modifying treatments yet. So I think that's an important agenda for the future, begging to be explored. And then all these things we've been talking about, despite the fact that we're now going to be able to intervene, are going to become even more important, because as we slow down mild cognitive impairment, that means you're going to spend more time in mild cognitive impairment, right? And if hopefully we don't get all the way to severe dementia, but people are going to still spend time in these stages of memory loss, and it's going to be really important to keep people mainstreamed in community and living to their potential. And dementia-friendly community will come into its own as an important agenda. Okay, so that's what I had to say. I really have the privilege to speak for my whole team in the Memory and Brain Wellness Center. Mary Grace, you met earlier with the banjo. Mary is really the driving force behind the Memory Hub. Dr. Rhodes, Chris Rhodes is here. Chris is the driver of the ADAPT program and our sort of therapeutically oriented neuropsychologist, and has been an amazing part of the team. And the other person in the audience I just want to single out is Mr. Richard Ferry, who's in the back row there. Richard, do you want to raise your hand? So Richard's generosity has really made the Memory Hub possible. So with that, I just want to thank you for your attention, and I'll be happy to take some questions. Okay, thank you. Okay, so why don't you ask the first question?
So I hear you working on Alzheimer's disease. What of these?
Yeah, so the question is, what about the non-Alzheimer's dementia? So it's a relatively short talk, and I decided to concentrate on Alzheimer's disease. But of course, we have patients with all of the other causes of dementia too: Lewy body dementia, vascular, cognitive impairment, and others. So a lot of these principles are equally applicable. People have different profiles of retained strengths, and I think it is a challenge for the future to define, what those different profiles are and how that we can factor those into treatment. But all the principles I talked to you apply as well to the other dementias, yeah. There was another question over here. Yes? So the question is, what about stimulation of the brain? She used the term bioelectric potential. There is work. There's a lot of work out there. People are using what's called transcranial magnetic stimulation, transcranial direct current stimulation, and I've also been hearing about like near-infrared visual stimulation of the brain. I had the privilege to hear a presentation from an engineering group that's working on that recently, and I am fresh from the Alzheimer's Center's kind of rendezvous meeting, and the trainees were presenting posters, and there's a young woman who won the Best Poster Award who was doing exactly that as well. So there is a lot of work on that. It's a very interesting area, yeah. Yeah, again, we don't understand all the biology of that, but I think it's got promise. Other questions? Anybody else? Okay. Going. And I'll be happy to answer questions individually too. So thank you very much for your attention. Thank you.
Great. That was a wonderful, informative, and educational presentation. Thank you so much. I really appreciate the part regarding building resilience. And this is what we actually try to do through the Osher Center and non-conventional modalities. The sense of belonging to a community, having a purpose, healthy diet, exercise, sleeping well, and just having fun with life. The journey is there. We go through the journey, so just let's have fun with it. So thank you for bringing that piece to our attention. And with that, I think we're going to conclude our session for tonight. Thank you very much for joining us, and hope to see you guys in our future events. Thank you so much. Have a good evening.